morning everyone. Today I am presenting a case report of secondary idiopathic intracranial hypertension presenting during the treatment course of VKH. As we already know, Vogt-Koyanagi-Harada syndrome is a primary autoimmune stromal choroiditis, can be associated with meningeal, auditory and dermatological symptoms. The treatment of choice being steroids and newly recommended combined steroidal and non-steroidal immunosuppressive agents. Non-responsive refractory cases are treated with biological therapy. Idiopathic intracranial hypertension is also known as pseudotumor cerebri. Is an uncommon condition of increased intracranial pressure that most often affects young obese women, frequently associated with headache, visual loss secondary to papilloedema. It is a diagnosis of exclusion. Idiopathic intracranial hypertension can be possibly caused by chronic steroid use, by increased CSF viscosity due to increased protein content and weight gain from prednisone. Coming to the history, a 40 years old female diagnosed with granulomatous panuveitis elsewhere 8 months back was on chronic systemic steroids on and off without complete recovery. She presented to us with both eyes diminution of vision and was diagnosed with VKH based on clinical features OCT and B scan and started on systemic steroids. 2 weeks after starting steroids, patient shows improvement in vision and was advised to continue steroids. After 25 days of therapy, she developed headache, consulted neurologist and was diagnosed as IIH and was advised to taper and stop steroids. 7 days after stopping steroids, she is complaining of gradual, progressive, painless diminution of vision of both eyes. History of left ear surgery 5 years back, details not known. She is hypertensive since 15 years on treatment. Coming to the ocular examination, the visual acuity of the right eye is 618 with pinhole improvement to 612. Near vision is N10. Left eye, the visual acuity is 618 parts to pinhole improvement 618 and near vision is N10. Slit lamp examination shows vitreous cells in both eyes and fundus examination with indirect ophthalmoscopy and 20D lens. As we can see, the disc is edematous and macular. There is edema and multiple SRF pockets were seen and vessels were tortuous, normal in caliber, and periphery shows multiple SRF pockets. And on macular OCT with HD 5 line, it shows multiple neurosensory retinal detachment with RPE undulations. And visual fields of CETA standard 30-2 with reliable parameter shows enlargement of blind spot with patchy reduced retinal thresholds. On an MRI, there is prominent CSF space along the optic nerve sheath on either side, with there is a flattening of the posterior sclera bilaterally, and there is empty cella sign. And summary, a 40 years old hypertensive female, which is a known case of granulomatous panuveitis, diagnosed with VKH based on clinical features OCT and B scan, started on oral steroids. 25 days after starting oral steroids, she consulted neurologist with complaint of headache and diagnosed with IIH secondary to steroid use and was advised to taper and stop steroids. 7 days of stopping steroids, she presented to us with complaint of bilateral diminution of vision with multiple SRF pockets, disc and macular edema on fundus. OCT shows multiple neurosensory retinal detachment with the RPE undulation and visual field shows enlargement of blind spot with patchy retinal threshold, a reduced threshold. Diagnosis is chronic incomplete Vogt-Koyanagi-Harada syndrome with steroid-induced secondary idiopathic intracranial hypertension. We managed this patient with immunomodulator methotrexate 10 mg weekly along with low dose oral steroid 10 mg. And after 1 week, vision was improved to 6/9 of both eyes. Vogt-Koyanagi-Harada syndrome is a primary autoimmune stromal choroiditis, may be associated with meningeal auditory dermatological symptoms. Our patient was diagnosed with granulomatous panuveitis and further with VKH, and on treatment with chronic oral steroids, she developed headache, and on neurology referral, she was diagnosed with IIH with increased CSF pressure and flattening of the optic disc with prominent CSF spaces around the optic nerve with empty cella. And after stopping the oral steroid, she again developed the same symptoms. And this IIH can possibly caused by chronic steroid use by increased CSF viscosity due to increased protein content and weight gain from prednisone. And there is one more study, Siddharth Gul et al. With a rare case of chronic idiopathic demyelinating polyneuropathy. The patient was on chronic steroid regime and frequently developed headache and blurring of vision with diagnosis of IIH with increased CSF proteins and systemic response to acetazolamide and elevated opening pressure on the lumbar puncture supported the diagnosis of IIH. So we conclude, we aim to emphasize the importance of keeping IIH in differential for a headache in chronic VKH patient on steroid as a possible complication of preventing catastrophic outcomes. Combined steroidal, non-steroidal immunosuppressive therapy can be considered for treating chronic VKH. These are my references. Thank you.
So good presentation, but I want to know, is a competitive session, suppose there is a Bhog Kainagi, first line of treatment is steroid. In such cases, what, as we know that there is some steroid related complication, to avoid those, what will be your protocol?
Sir, actually we can start with steroid first, as our patient was on chronic systemic steroid since 8 months, on and off. Because of chronic steroid use, there is increased of viscosity might have happened with increased weight
I'm
gain.
just asking, what would
Yes,
be
sir.
our protocol if we start steroid? We can instruct some few things to the patient
Yes,
to
yes.
avoid the complications.
After starting steroid, we should ask the patient to, if she has any complaint of headache or increased weight gain, we should monitor the patient. If she is having any kind of complication, we can reduce the systemic steroids and can start non-steroidal immunosuppressive agents along with low dose steroids.
Yes, apart from some others like a diet, proper control of the blood pressure, proper control of sugar, chronic renal function test, periodic renal function
Yes.
test, those are the points. If we can do, generally we can avoid most of the time. She or he can do some physical activity daily, low carb food, proper water intake, and the dietary balance. That's important. Okay. Any question?
So excellent point made by sir. So I deal with a lot of patients of uveitis, so we end up using steroids quite often. These are all the instructions that we need to give. Actually spend 5 to 10 minutes to ensure that the patient doesn't gain weight because of steroids. Number one. Number two, in VKH, so that is looking like VKH, and it is good that you've done the lumbar punctures, otherwise we would have called it headache and meningismus related to VKH. What's new about VKH, or probably even known now, is that you start immunomodulators right up, straight away. So when you get the first or second attack, you just straight away start the patient on an immunomodulator. And probably the drug of choice is Azoran. Here you have used methotrexate, but the response seems to be fine. Maybe the response is right now to steroids, because you've shown it only at 1 week. Methotrexate wouldn't have acted in 1 week, but nonetheless good presentation.